Good morning, everyone, and welcome to the Winter SEOW meeting. I'm Sharon Merriman-Nai. I'm here at the Center for Drug and Health Studies, and I work on the facilitator team for the State Epidemiological Outcomes Workgroup. We are going to get started now. The meeting is being recorded. You are all muted upon entry into the room today. If you haven't already, please introduce yourself in the chat. We have a very large group of people today. I think we're expecting over 80 folks to join. And we have a lot of newcomers, which we're excited about, but we're also happy to see everyone that we have been working with for years. So that's very exciting too. We've got a really packed agenda. MJ, if you want to advance to the next slide. And the next one. So first of all, we want to thank the Division of Substance Abuse and Mental Health in Delaware for sponsoring the SEOW. They do that with funding from the Division of Substance Abuse and from the Substance Abuse and Mental Health Services Administration at the Department of Health and Human Services at the US government. We're grateful to be carrying on this work. We've done this for about 12 years now. This originally started as Delaware Data. It's been rooted in the Strategic Prevention Framework initiative that was initiated back in, I think, about 2008. So we're happy to be here and to continue on with this work. If you'll advance to the next slide. As I said, we have a packed agenda. We're very excited about it. We're excited to see everyone virtually, if not in person. But I do just want to take a minute to say on behalf of the SEOW team here at the Center for Drug and Health Studies that even though we have found ourselves in extraordinary circumstances during the past year and many challenges, we've observed that the work in Delaware in terms of prevention and intervention and treatment for behavioral health issues has not skipped a beat. I mean, we've had to change gears, but the work that you are all doing is still quite impressive. It's needed now more than ever. And we just want to give a round of gratitude to all of you for continuing to carry on with the work that you're doing. So thank you very much. Just briefly going to go over the agenda. We're doing welcome and opening announcements now, and we'll do a little team introduction in a minute. Then I believe it's Laura Rapp is going to give a quick overview of the goals of the SEOW and share out a little bit about our accomplishments of the past year. We do have a little surprise announcement. We've got a few data champions we want to recognize. And then we're going to move into our presentations. The first one will be a national behavioral health landscape overview and a breakout discussion. We wanted to kind of fill folks in on what's happening nationally around these issues that we're experiencing. Then we're going to move into a presentation with Dr. Khaleel Hussaini, who's going to talk about adverse childhood experiences based on data from the National Survey of Children's Health. We'll follow that up with a positive childhood experiences report out from MJ Scales. It'll be a little bit of an overview and a taste from what's coming in one of our new gap reports. Then we have our colleagues from the Division of Substance Abuse and Mental Health who are going to present on a mapping naloxone distribution in Delaware initiative that's recently started as part of our effort to be strategic in our response to the opioid crisis. We'll do a very quick overview of some of the findings of our satisfaction survey among you all who participated last year, which will inform us on how to improve the services and the products that we develop here at the SEOW. And then we'll have a network member share out. Now, I do want to just give a bit of a disclaimer. As you know, if you have been here before, we have had on occasion, like every occasion, run over our time slot. We don't intend to do that. We try very hard to stick to our timeframes. However, what we find is that conversation is very robust. People have a lot that they want to share and comment on. So we're striking a balance between staying on task and staying on time and allowing people to have that time to be able to pose their questions and share their thoughts. If we do run over, we do understand that 2 hours is a big time commitment for everyone. And if you do need to go, we certainly understand that. But we will probably carry on a little bit after the fact. For those of you who want to pose questions throughout, please use the chat. If you want to share information at any point or a resource, please use the chat. We do take that information and we sift through it. We synthesize any highlights from it and any announcements, and we make sure we do circulate that when we circulate the minutes from the meeting, the slides from the meeting, and the notice of the recording being posted. Without any further ado, I'm going to turn it over to MJ Scales, who is the co-PI on this project, and she's going to do some team introductions now. Thank you. MJ?
Good morning, everyone. As Sharon mentioned, there's about 90 people on the Zoom today, and many of them are staff and students that are affiliated with the center, and I'm happy to introduce all of them to you today. They'll be either presenting, facilitating, or supporting, our meeting today in some capacity. Our Master of Ceremonies, Air Traffic Control, Sharon, pick a metaphor, either one will work. Captain of the ship, Dr. Rapp, obviously is here with us. Then we've got David and Bill working some tech magic, but also just lending their general expertise to the conversation. The PIs of the school surveys, Jim Heiberger and Dr. Rochelle Brittingham, are joining us today. We've got a great presentation coming up from Rachel Ryding and Dana Holz. There are some other colleagues from the center, Dr. Cheryl Ackerman and Eileen Sparling. Some more colleagues, Jessica Arnold and Solange Ely, are with us today. We have our director, Dr. Christy Vischer, retired, but not really retired. They do it different in Delaware, Steve Martin. And none of our work at the center would be possible, this meeting included, without our great graduate and undergrad students, Brandy Pugh, Rachel Schilling, Maddie Miller, and Marley. I think I got everyone. Hope that's everyone. And next, I'm going to turn it over to Dr. Rapp. Oh, and I'm MJ. Everybody knows that already, right? I'm MJ Scales with the center also. I'm going to turn it over to Dr. Rapp for the goals.
Thanks, MJ. So we touch base on the 4 goals at the top of every meeting for the SEOW. And towards the end of our year, we also recap some of the major activities, accomplishments, and barriers of the SEOW for the year. And I used to say that this was my favorite report to put together, but Sharon actually put it together this year. So now it was one of my favorite reports to read instead of actually typing it out. So thank you, Sharon, for doing that. But as was mentioned, the State Epidemiological Outcomes Workgroup originated from a calling from SAMHSA, and they outlined 4 major goals that our Delaware SEOW has implemented for over 10 years now. So we wanted to just ground this conversation in this meeting into as to what those 4 goals are. The first is to identify, analyze, and share data. I think everyone's on this call because they're interested in behavioral health related data in some capacity, and we are one of them. And what we like to do is look at over 30 different data sources of either Delaware data or national data, a lot of which you're actually going to hear about today in the presentations. Analyze some of those data sources and then push the data out to people who need it so they can make data-driven decisions. One of the largest products we work on is our epidemiological report, annual report, which comes out every year and is on our website, which has a number of chapters related to a lot of the different substances of interest, as well as related protective factors, and some consequences associated with substance use as well. The second goal is to create data-guided products. We do that through a bunch of different mechanisms, and you all provide a ton of wonderful feedback on the different data products that you would find helpful in your work in your field. Some of those include heat maps around substance use and resources. We have a number of Venn diagrams. We also push out infographics, and we have a lot of resources on our website as well. The third goal is to train communities in understanding and using data. And I think this is something that, again, hopefully everyone on the call is invested in. It's really important that we know data and we understand data, but to also make sure the people that we're working with and the people we're collaborating with are also invested in the data, and to hear from them, from their expertise as to, is the data speaking to them or not? Does it complement what they see in their lives? And how can we all interpret the data and all use the data in our programming and in our activities? And the fourth is to build state and local level monitoring systems. And this meeting is also another way to do that, as well as listservs and other agency representation through other different work groups and task forces. I think the next slide, MJ. So we were thinking about this last goal in particular around monitoring systems and how we get information out there. And it really kind of dawned on us that the SEOW wouldn't be as effective as it is without all of the great work that the people on this call and people who can't join today are doing in their work life, probably in their personal life too, when it comes to championing data. And we know that data is only helpful and only going to be useful if people are out there talking about it, using it, and improving systems. And we were reflecting back on how wonderful Delaware is when it comes to some of these data champions and how fortunate we are as an SEOW facilitator team to have such invested individuals, some more recent, some for many years, when it comes to using and sharing data. So we wanted to take a minute as an SEOW and say thank you and to recognize 2 of our data champions. And we're hoping this is something that we can do on a regular basis during our meetings, because the SEOW wouldn't work without you guys. We can only do so much, but then you guys go and take the data, you spread the message, you use it in your programs, you use it in your media campaigns, you use it for policy development, you give us feedback on our products, you tell us when we're wrong so we can correct things and make them better. And we truly appreciate that. So we just wanted to take a minute or 2 to recognize 2 of our colleagues that we see. Oh, that's my 2-year-old in the background, giving her crackers. That we see as data champions, and we just want to say we appreciate you. The first is Dr. Gloria James, who I saw signed in, so I know she is here. Dr. Gloria James has been involved with the SEOW for many, many years, and we really see her as a true champion and advocate for data, especially around building data collection systems and building data infrastructure in the state of Delaware. How do 2 data systems talk to each other? Are they producing the data that we actually need and use? And in addition to that, she's also a member on different groups and task forces and brings that data lens to all of that work that she does. So Dr. Gloria James, we thank you for being an SEOW data champion. You will receive this beautiful PDF. You can use it as a Zoom background if you choose, or you can hang it up on a wall, but we appreciate you and we thank you for being a data champion. And maybe a muted or unmuted round of applause. Thank you, Dr. James. And in addition to that, we have another data champion that we wanted to highlight, and that's Dr. Bill Lynch. So when I mentioned Dr. Gloria James, when I think of her, I think of building all these data structures, building this data infrastructure in Delaware. When I think of Dr. Bill Lynch, it's someone who is shouting about the data and how we can use the data in Delaware to inform all of our programs and to just make people more aware of what's available. Dr. Lynch regularly goes out to PTA meetings, conferences, different groups all throughout Delaware, coalition meetings, talking about the data and sharing the data. He even has shared some of the SEOW data elements to, I think, conferences in other parts of the country as well. And he has this other cool aspect where he's in New Jersey and he's in Delaware. So he's also able to kind of give us a little bit of an understanding about what other states are doing and how they're tackling it and how they are using data. And hopefully we can learn a bit from New Jersey and New Jersey can learn a bit from us. So Dr. Bill Lynch, we want to thank you for being a wonderful SEOW data champion for the state of Delaware. Your efforts are noticed and appreciated. So thank you both very, very much. And I'm going to do another round of applause. And again, you will also receive your PDF in your email. Hopefully it is the best email of the day for you. But we really just wanted to thank you guys. And I know we can and we plan on highlighting different SEOW members for your individual and collective contributions. So thank you guys sincerely from us, the SEOW team. And that's it, meeting's over. Just kidding. Now we're gonna get to why we are really here, which is to talk about all the data that everyone in this group loves. My colleagues, Dr. Dana Holz and Rachel Ryding, are going to share a little bit of information from the national landscape. Recently, a lot of national data sources have come out around behavioral health, so we wanted to just share that information. Some of it was pre-COVID, some of it is during COVID, but I think that they're going to give you a really wonderful overview. So I'll turn it over to my colleagues, Dana and Rachel.
Thanks, Laura. Hi, everyone. I'm Rachel Ryding. I'm going to be presenting with Dana Holz. We're going to talk a little bit about the national behavioral health landscape, some of the latest trends pre-COVID from the national data, and then a little bit of what we do know about behavioral health in this COVID era from the data that is available. All right, so first I'm going to start off just talking a little bit about an overview of national behavioral health data prior to the COVID-19 pandemic. So we have some data from National Survey on Drug Use and Health, as well as the National YRBS and the National Monitoring the Future Survey. Some things that we know from National Survey on Drug Use and Health regarding prescription opioid misuse and overdose fatality rates. In the years leading up to the pandemic, up to 2019, we are seeing some declines in past year prescription painkiller misuse, particularly those sharpest declines among that 18 to 25-year-old age group. But we're still seeing increases in overdose fatality rates. And Delaware is one of the states with the highest per capita overdose fatality rates. So there are, even though prescription misuse may be declining, there's still definitely a lot of concerns regarding overdose rates. And Dana will talk a little bit more about some data, what we do know about how overdose rates have continued to increase during the pandemic. And then from some CDC data, just looking a little bit more about what some of those drugs are that are involved in the high overdose fatality rates. And those are typically the synthetic opioids are involved in most of the overdose deaths, and that's where we've seen the sharpest increases. So these are things like fentanyl. We also have from the National Survey on Drug Use and Health data on an increasing unmet need for mental health services. And again, some of these sharper increases are among that 18 to 25-year-old age group. So those increases in unmet need have been particularly strong for younger age cohorts. We've also looked a little bit at national suicide data. And when we look at adults who've had thoughts of suicide in the past year or who've made a suicide plan, again, we see prior to the pandemic, there'd been increasing rates, again, among that younger adult age group in particular, seeing increases up to 12% of 18 to 25-year-olds saying that they've had serious thoughts of suicide in the past year. And when we look at national data on high school students related to having plans for suicide, we've seen that over the past 20, 30 years or so, it's declined some, and then it's started to come back up again. And this last relevant data, available data for this particular survey is from 2019. So again, we will probably see more about this youth data in 2021, perhaps, and see if this has changed at all. And then the Monitoring the Future survey is a national survey of 8th, 10th, and 12th graders, and they actually have some data from early 2020. Their survey was launched and then the pandemic happened, so they had a much smaller sample in 2020 than usual, but we do still have some slightly more recent data from them. And some of the things that they found nationally was that, while we had been seeing these really rapid and concerning increases in teen vaping, in their 2020 data, those increases seem to have leveled off. So while there's still a lot of young people who are vaping, that it's not increasing quite at the same rate as it was. It seems to have leveled off, and particularly Juul use has declined significantly among older grades of students. We also see that marijuana vaping has decreased some among some groups of students as well. And marijuana use hasn't really increased, but hasn't really decreased too much. That's something that's remained steady among students at the national level up until early 2020. And while we've seen a lot of overall declines in alcohol use among youth, those declines seem to be leveling off as well and kind of getting into a plateau point. So I'm going to turn it over to Dana now. I can continue advancing the slides, Dana. And she's going to talk, now that we've gone over a little bit of the national data, what we knew up until the point of the pandemic, she's going to talk a little bit more about what do we know from data that's come out during the pandemic about how any of these indicators might be affected.
Thank you, Rachel. So I'm going to go over a couple of data sources. I just want to note right off the bat that a lot of this is preliminary. Some of the surveys that are referenced here are limited in design and scope. So this is just a first look at data from the pandemic on, and hopefully we'll be seeing more and more reports. The first resource around children and families is a project at the University of Oregon. It's called the Rapid EC. It's an ongoing nationally representative survey of households of children 0 to 5. They have on their website a variety of research briefs. They're very interesting. But one of the things that they have found is that parents in particular are experiencing very, very high rates of stress with single parents, low income families, and parents of children with special needs experiencing the highest rates of stress. Because of this stress, it's also affecting children as well. So parents who are experiencing stress are reporting their kids are also experiencing stress. Also, there's been a decline in preventative care and vaccines, as we've heard in the news as well. Next slide, please. So there's been a couple reports put out about mental health status of Americans. Unfortunately, it's not great. One of these resources, the APA, they adapted their annual Stress in America poll for a monthly analysis. One of the reports they published from this resource from April to May found much higher stress levels than what they found in the 2019 survey. Again, particularly parents reporting very high levels of stress, and Hispanic community experiencing the highest rate of stress, which is actually comes up in other resources as well. The Hispanic community is experiencing very high rate of stress right now. A fairly alarming report published from the CDC's MMMW Morbidity and Mortality Research weekly report looked at pediatric mental health related ED visits. And overall, all ED visits declined during the period between March and October 2020. And that was partly because there was a big public push to not use EDs for anything but extreme emergencies. There was also a decline in mental health related visits for children. But during that same time, the proportion of kids who were coming to ED for mental health reasons increased dramatically. So this is, while the number is slightly less than the previous 12-month period, it's still alarming because there was this public push to not use EDs and the proportion is pretty high. So an increase of 24% among children aged 5 to 11 and 31% among youth aged 12 to 17, showing that the pediatric emergency departments were really working with a lot of kids with mental health needs during this period. Next slide, please. The Household Pulse Survey is a survey from the US Census Bureau and the National Center for Health Statistics. They push out the survey in 2-week increments, and then in different phases, they analyze the results. The most recent analysis of these results is that 4 out of 10 surveyed Americans report symptoms of anxiety or depressive disorders. This is alarming because using the same set of questions from the National Health Interview Survey in 2019, only 11% of surveyed Americans reported these symptoms. So we're seeing pretty dramatic increase in Americans who are reporting symptoms of anxiety or depressive disorders. Another CDC-funded survey from June 2020 also found very high rates of depression, also increased reports of substance use, increased suicidal ideation, and again, symptoms of anxiety disorder or depressive disorders. One of the most alarming things that came out of this survey is that 11%, almost 11% of the respondents reported suicidal ideation within the last month, which is in comparison to a similar question from the NISDA in 2018 of about 4%. So again, pretty dramatic increase in people who are reporting suicidal ideation during this time period. Again, they noted some populations, and this is also some populations as well in the American Pulse survey, Household Pulse survey. Young adults in both of these resources are experiencing very high rates of depression, anxiety. This is 18 to 25, Black and Hispanic adults. And this last study showed unpaid caregivers for adults and essential workers who are experiencing higher rates of suicidal ideation, substance abuse, and so on. One data resource that's very interesting. It's a EMS data from 47 states. It can be activated at the scene of the the incident. So it's almost real-time data. It also has a massive amount of data. Last year was over 25 million activations of the system. And so you can see the red line is when the stay-at-home orders, about when most states had the stay-at-home orders put in place, or when there was starting to be kind of community spread. So sorry, the red line is when there was starting to be community spread of the coronavirus. The blue is when the stay-at-home orders started kind of phasing in, and then they fade out coming about May. And so that's kind of your marker for when you see when things are happening. So the good news at this point so far is that despite people reporting more suicidal ideation, the data at this point are not showing an increase in suicides. Not just this, but another study looked at this. But we are seeing an increase in mental health needs. You can see in this other one, the rate of mental behavioral activations. And these are things for example, major depressive disorder, let's see what else? Anxiety, altered mental state of emotional shock, strange inexplicable behavior, et cetera, would be under this other category. So there have been more EMS activations for mental health reasons. Next slide, please. Moving into substance abuse, two different reports that had nationally representative surveys have found increased drinking during the pandemic. One from March and April 2020 found a 29% reported increase in drinking compared to the similar time period with a different survey. Again, this is fairly preliminary. Some populations reporting more use than others, women, adults under the age of 40, and then those with symptoms of anxiety or depressive disorders were reporting almost up to 60% more drinking. So that population in particular is experiencing high rates of drinking. Next slide, please. So this starts with before the pandemic, but it ends May 2020. But unfortunately, this time period, we saw again an increase in fatal drug overdoses, 18.2 increase. As Rachel noted, most of this increase is related to synthetic opioids. However, cocaine and psychostimulants have increased dramatically in the 12-month period as well. Next slide. And you can look at this map and you can see that Delaware fortunately hasn't had the highest increase, but we're over here in orange with between a 10 to 19% increase in fatal drug overdoses during the 12-month period. Importantly, after the pandemic, there was a surge. So some of these numbers, these increases were driven from that time period after the pandemic. And that's, again, using the NEMSIS data, you can look at the opioid-related activations, and you can see a peak for both activations with naloxone as well as opioid-related activations right around when they're phasing out the stay-at-home orders. You can see at the end of the blue. And unfortunately, in both of these, you can see that it was starting to increase again coming into the new year. Next slide, please. So for those who have a substance use disorder, this is the last slide here. A NIDA supported survey of over 1,000 respondents with a substance use disorder conducted last spring found that 1 in 3 reported changes or disruptions in accessing treatment or recovery support services. 14% reported being unable to receive services, and 4% reported an overdose since the pandemic began. Also, finally, it's important to note that a new research report that came out just recently found that looking at US electronic health records, those who were diagnosed with a substance use disorder within the past year had an increased risk for COVID-19 and also fared worse than other people. So while they're not currently listed as one of CDC's vulnerable populations, the research is indicating that they are very vulnerable to COVID-19, so it's something to think about. And that is the end of the data. I just wanted to say, this is not the happiest picture of data right here, but for a lot of people who are on the call right now, you've worked very tirelessly and hard this year, and this is, this is a time when people need you the most. So thank you for all your work. And then there's just references.
All right, folks. So I know that there's a lot to unpack there. I know we're excited to talk about that and get into that. So we're going to do that in breakout rooms because there are a lot of us. So this is probably a better way to do it. The question that will be posed is, does the national picture reflect what you and or your organization are seeing locally? I'm going to send you to your breakout rooms with the caveat that if you registered sometime after 9 o'clock last night or first thing this morning, you're not going to auto be pushed. I'll have to manually push. So just be patient, okay? 1 second, please. Hi, everybody. Welcome back. Thank you for coming back. I'm excited to hear what was going on in the groups. I'm sorry we only had the 10 or so minutes for conversation, but the facilitators of those groups will report out for the groups. But if you have things that you want to add or keep going with the conversation, please include it in the chat. First up, Rachel. Ryding, sorry, there's more than one Rachel. My apologies, Rachel Ryding.
There we go. Thank you. Sorry, I couldn't unmute myself. But yeah, we had a great discussion in our group. We talked a bit about just impacts of schools being closed and that impacting referrals and things like that. But we also had a really good conversation about the different ways and the different stressors that people are experiencing right now, and really thinking about those social determinants of health and how that all plays into how people are experiencing and responding to the conditions of life right now and outside of the context of the pandemic. One person introduced the word syndemic as a way of thinking about the synergistic effects of all of the different economic and social and other structural impacts that interplay with the pandemic that make things difficult. And then we talked a little bit about, how can we uplift and think about protective factors and build some of those things up to help reduce some of the negative impacts of the pandemic.
That's really cool. I'm taking notes. I love facilitating these things, but I always learn a lot too. I like that syndemic. That's cool. Mr. Heiberger, your group.
Thank you, MJ. So one of the things we discussed is the increase in drinking culture, or the acceptance of drinking culture, especially on social media, and how daytime drinking is seen as kind of a fun activity opposed to maybe underlying health concern, which could be an impact of the pandemic and kind of our changing environment. But I'm going to go on a different thing and point out one of the benefits, because I think we need a little bit of positivity after that presentation, is Mindy Webb pointed out that through the telehealth and mental health screening, they've gotten a higher participation and less no-shows, and even increased capacity for mental health screening. So that is something that we do have something we have to look forward to. the Delaware School Survey has also introduced questions about telehealth and participation in these types of programs. So I'm excited to see what this data has for the future and this new resource that we may have.
Neat. Thank you so much for sharing. Dana, your group. Dana Holz.
Sorry, it took a while to unmute. We talked a little bit about the presentation, and unfortunately, some people did see that in their experiences with their clients, more depression, anxiety, as well as their family members. We talked a little bit about how different age groups might be experiencing these things in different ways. So for young people, it might be anxiety, but for the oldest members of our community, it might be isolation and depression. So the same ways of looking at mental health should change by different age categories. We also talked a little bit about that silver lining of there has been so much conversation around mental health this last year that perhaps one good thing is that more people will not feel the stigma of getting mental health support. And, you know, maybe there's a way that because we're all kind of in this together, that will be a protective factor because it's something we weather together. About it, I think. Oh, and then we also talked about a barrier, about the challenges of getting survey data, particularly for YRBS and other things like that.
Yeah, that's huge. Your group is spot on. You know, we're talking about it more. It's in everyone's face more about mental health. There's less shame attached to that because we're all struggling. So that's really exciting. Dr. Brittingham, your group.
So similarly to what some of the other breakout rooms had discussed, I mean, there was a acknowledgement that national trends are also being seen locally. You know, we're kind of following with that. More specifically, in terms of gambling and kids playing video games, predatory gambling has been occurring still online, even though that there are laws in place against that, because students and kiddos under the age of 18 are now playing, you know, 4 or more hours of video games a day, which is a pretty big increase from pre-pandemic times, just because people are home now and doing a lot of virtual school, so they sort of have access to it, as well as adults indicating that they too have been gambling more frequently. Something that kind of diverged from the national trend on one of our discussion points was that vaping in one of the data sources indicated that it was going down. That hasn't been this participant's experience. In fact, with some youth focus groups back in June, the youth were indicating that vaping and marijuana use had actually been going up to the point that some people were hosting Zoom social hours with vaping and marijuana being a primary theme of the particular Zoom calls. But kind of switching to protective factors, also acknowledging that adults are in the community and saying, if I don't have access to these kids to provide a positive role model experience for them, you know, we're concerned about what might happen. And there are agencies, you know, with the FQHCs that are talking about how to advance healthy lifestyles and doing like cooking classes and yoga, how to make meals under $10 to really continue to engage the community in ways that would not have been possible before, i.e. using Zoom or some other non-face-to-face technique. So.
Yeah, that's great. There's a lot of community level creativity happening, and folks have really great ideas about how to keep, you know, bonding even from a distance, right? Dr. Ackerman, your group.
Sorry. Going later in this line of reporting out, so many of the things that have already been mentioned were also discussed in our session. The whole idea of people spending a lot of time together, both having positive or negative consequences, because there's been an increase in violence or the severity of violence in homes, as well as one of our group members talked about that there's been an increase in social connectedness from the clients that she works with, which, you know, I'd love to hear more about. We didn't have a chance to get into that, but they're feeling less isolated. So that's, you know, that's a positive. We also talked about, we also had someone comment on this notion that, you know, they were surprised that the data showed a reduction or a decrease in the use of vaping and Juuls and things, where, you know, her experience is that that's not actually the case. In addition, was reported that some of the resources that had been typically used for kids, the school-based clinics, health clinics, because they were closed down, they were no longer a resource available to the kids. And so the kids didn't have access to them. And also because the schools were shut down, certain outreach was no longer possible. So those were you know, real concerns. What else? And we actually, I asked about what kinds of other things people might be interested in learning about. And one thing that was raised was learning more about the social determinants of health as a result of this. So I know that that notion was brought up earlier in one of the reporting out, but ideas about, you know, like food availability and housing problems with all the craziness that's gone on with that. So I think those were our main takeaways. Thanks.
Thank you for sharing that. Yeah, it's really interesting, right? Because I might be vaping more because of stress, because I'm more stressed, but if I'm usually vaping with my friends and I can't see my friends, am I vaping less? So it's this weird relationship that could be substituted for drinking alcohol or smoking marijuana or any of those things. So it's an interesting relationship between use and behavior. Last up, Sharon, and then Sharon, you're gonna roll right into the next section. So I'm gonna stop sharing my screen so you can move on after your share out.
Okay. Yeah, to echo what Cheryl just said, a lot of folks, you know, like I've already reported on a number of the themes that we touched on. In our group, we actually had 3 direct service folks working, a couple of them in Southern Delaware and also one in New Jersey, Dr. Lynch. And the takeaway was that the numbers that they saw, as bad as they were probably not as bad as they actually are in their experience and working directly with youth and with other populations. So that's something to bear in mind, that the data we're seeing, as was mentioned, is preliminary and it's lagging. So we probably are looking at a worse picture than that. We also did have a discussion about the increase in video activity, video gaming, and within that, not only the video gaming, but the gambling within the video gaming, and how sometimes that's not on our radar. That was mentioned earlier as well. And also the theme of, you know, we are not in one pandemic, we are in multiple pandemics, and that they feed off of one another, and that the ramifications of all of this are going to be felt for a very long time. To that end, a couple of us had mentioned the concept that our healthcare folks in particular, not just behavioral health, but our healthcare folks are really bearing a lot of the psychological, you know, they're really on that front line. They're really absorbing a lot of this, and it's really taking its toll. There was an excellent webinar yesterday that I posted in the chat from the Harvard School of Public Health that you might want to look at if you want to get a little bit more of a flavor of the kinds of things that people are experiencing. And then finally, the other thing that we wanted to say is that, you know, that there are resources for all of this, and that, you know, we're hoping that that we are able to harness this data in the future, but that some of the positive and protective things that we've heard folks mention are things to kind of look forward to and build upon. One notion I did want to mention is that one of our clinicians had said what they are seeing that's so shocking is that there are many kids who are presenting with no history of psychological issues whatsoever, who are suddenly becoming suicidal, and that severe change is extremely alarming. So to bear in mind that we're not just seeing greater numbers, but the severity of what we're seeing is actually much more than we might be expecting or might be thinking we're seeing. So with that, I'm going to wrap up this section. We're going to move on to Dr. Hussaini now. who's going to talk about the ACEs data. I'm going to give a little introduction. You're going to have to pardon me because now I have to share my screen, and I'm going to give an introduction, and I'm not really good at multitasking when technology is involved. So I apologize for being a little incoherent at the moment. But I do want to introduce Dr. Khaleel Hussaini, who is with the CDC, the Division of Public, he's working at the Delaware Division of Public Health. He's been here since 2016, and he is working on maternal and child and health data. He's helping to build an inventory of that data here at the state level and also providing technical assistance. I first met Dr. Hussaini in his work with Trauma Matters Delaware on the data committee. He has been a vital resource to the SEOW, has provided a great deal of analysis to us over the years for the issues of adverse childhood experiences, drawing heavily upon the National Survey of Children's Health, which he's going to talk about today. So I want to thank him for all of the help he's given us in the past, as well as this presentation today, because his data has been incorporated over the years into our Epi profile, into other products as well. So I'm going to turn it over to Dr. Hussaini. I will be advancing your slides once I have all of it, once I get the presentation mode going. Okay. So are you ready to roll, Dr. Hussaini?
Thank you, Sharon. Thank you for the kind words. Welcome, everybody. Thank you all for taking the time. And I think before I start off, I want us to just take a moment to just kind of be thankful and grateful for everything we have, and you know, imagine that things could be a lot worse. And I want to kind of, although we're dealing with something that's very heavy in terms of discussion, I want us to look at the positivity and the hope that we could definitely be more resilient. So having said that, again, thank you. So next slide, please. Just as a quick caveat, I want to kind of say that, you know, the opinions and the views expressed here have are individual solely, mine, not reflective of Delaware Division of Public Health and or Center for Disease Control and Prevention. So I don't know if all of you are familiar with the National Survey of Children's Health, but in essence, this survey is funded by Health Resources Services Administration. It used to be biannual, you know, every 2 years. And then starting 2016, they did a big revamp, and it's now available online. The survey is actually fielded by the Census Bureau, U.S. Census Bureau. And just to kind of give you a quick overview, I can't see it on my screen, but I presume you can see in yours as you're looking at it. You know, this presentation that I'm going to be doing is for the last 4 years. And so, you know, when we first started off the survey, we had about 50,000, you know, interviewees during the first year of data. And over time, you know, the sample sizes declined. And you see both the US and the Delaware sample sizes, you know, we're fortunate because our Delaware data with 1 million residents in Delaware, approximately, we still have about 500, you know, cases. Some of the larger states also have similar samples to Delaware. So we're fortunate that, you know, our data is pretty robust from that perspective. So this data is a compilation of the 4 years from 2016 to 2019. Next slide, please.
Khaleel, I'm sorry, I'm having some challenges with advancing the screen while I'm in the Zoom
No worries.
room. I apologize.
No worries.
Let me see. I'm going to start the share over again.
Okay.
Okay.
So as you know, Sharon works through her magic. How many of you are actually all familiar with the National Survey of Children's Health? You know, if you can just kind of put it in the chat box, that'd be great. You know, if not, that's fine as too.
So
Go ahead.
we were able to move the screen. I'm not sure if I'm doing it or if MJ is giving me an assist somewhere else, but it did advance.
Okay, fantastic. So basically, this National Survey of Children's Health has two components. One is basically the screener, which basically looks at the eligibility of families that are going to be interviewed, and then the topical responses where a lot of the questions and measures are derived from. So there are about 18 of those measures, you know, 7 domains, you know, physical, oral health, emotional and mental health, insurance coverage, healthcare access, community and school activities, and a variety of indicators. So it's a massive survey. Next slide, please. Do you want to zoom out, Sharon? Maybe that's probably helpful if you can get on the presentation.
Yeah, sorry.
No worries.
Is it okay if we do it without the big screen then? Because it won't be in presenter mode. I'm really sorry.
Oh, no worries.
Okay. Okay, let me go back to sharing the screen. Okay, can you see that?
Yeah.
Okay.
Yeah. Okay, so this is basically the demographics of you know, comparing Delaware and the U.S. And you know, basically what it says is kind of, you know, what this table is showing is, you know, our population is more or less similar, except with one exception. We have something called children with special health care needs. We have approximately 1 in 5 Delaware children whose parents identify that the children have special health care needs as compared to the national data. You know, we have obviously a larger Black and African American population. Besides that, I think most of the, and we have also, interestingly, you know, a larger percentage of parents who are third generation or higher. They're both the parents were born in the U.S. Compared to the nation. So these are some kind of contextual information for you to kind of think about when you're looking at the data, looking at the findings, what we're going to see. Next slide, please. So the topic we're really interested in is the adverse childhood experiences, which is part of the topical questionnaire. And this is, it's important to understand, this is the, these questions are asked to the parents because the survey is administered to 17 and below. And so the parents are responding on behalf of the children. So, to the best of your knowledge, has this child ever experienced any of the following? So there are 9 items. Item 1A is hard to cover basics like food or housing. This is not really a traditional childhood experience item. The rest are. and then the treated unfairly because of race also has not typically been perceived as a traditional adverse childhood experience. So bearing that in mind, the person and a lot of the folks in the maternal child health, we view all these as ACEs. So as we kind of move forward with looking at the data, I want you to kind of have this picture. Next slide, please. So when you look at the individual trends for these ACE items, if you remember, there's for folks who have great vision, you can look at the footnotes below, but you see there item number 2, which is basically death in the family, and item number 3, which is basically parent or guardian divorce is item number 3, death in the family, and violence, victim of violence, and item number 9, which is perceived discrimination, treated unfairly because of race. We are trending in upward direction, which is very interesting. One of the areas where we've made progress is the incarceration. The perception that we've generally been much higher compared to the nation. So that's one experience that we're now similar to the nation in terms of responding to a family member being incarcerated or not. What was really interesting to me is the item 9, which is very interesting to me, and we've seen a pretty significant increase starting 2016. I mean, I don't present the data. When I looked at the demographics, almost, the prevalence estimates for Delawareans who identified themselves as Black or African American was about 10 to 12% in comparison to non-Hispanic whites, Latinos, and in fact, another group that was very high was other race and ethnic groups, who kind of viewed that they perceived that they were being treated unfairly. So, which is very kind of interesting. And if you look at the time period, this is the 2016 to 2019, we're seeing an increase, not just in Delaware, but also nationwide, which is a very interesting point. And the third one item was basically, death in the parent or guardian who has died. We've seen a whole lot of fatalities, and in schools, kids reporting that one of their family members died either because of an overdose or some other related thing. We've seen that, and it seems to be reflected in that the number of children who indicated that one of their parents died has increased, and is in the not in the optimal direction. And I think the 6th item is the violence piece, which I think in one of our breakout session they were talking about. We made some progress, and we're starting to see again an increase. And post-COVID 2020, we'll see how this will continue to increase. Next slide, please. And this basically is looking at a combination of all the ACEs. So you have unexposed and one adverse experience, any one of the experience or 2 or more. So Delaware generally has slightly higher number of respondents saying that they've experienced 2 or more adverse childhood experience compared to the nation. There's a 3 percentage point difference, in 2019, and that's kind of remained increased, that difference has been as consistently remained over time. So next slide, please.
Excuse me, Dr. Hussaini, some folks are having a hard time hearing you. Would you mind either speaking up, or maybe there's some muffling going on your end with your mic?
Sure. Can you hear me better now? I'm using my webcam. here. Can you hear me better, MJ?
I think so. Is everyone else hearing okay? Yes, it looks like that's better.
Okay, fantastic. So this particular chart is, pretty self-explanatory. We don't see any significant gender differences by ACEs, whether with or without exposure status to one or two or more. Next slide, please. Okay, and this is with children with special healthcare needs. In general, we see those children with special healthcare needs, have much higher reports of adverse experiences in comparison to children without special healthcare needs. So there are more vulnerable populations. Next slide, please. This is stratified by age groups. Obviously, the adverse ACEs seem to kind of increase with age. And more reports, older children are more likely to report more ACEs in comparison to younger children. Next slide, please. And this one kind of breaks down the ACEs by generation status I showed you earlier, and this is a very fascinating because as a social epidemiologist and a sociologist, the generation status of the parents. These are, if you look at this particular group, there's a pretty strong, or rather almost twice the difference among, parents, not parents, parents whose parents are not listed, and these are children who are born here in terms of their ACE responses. The 47.5 as compared to, what we call any parent, who's born here. So that's an important aspect that you want to probably think about. What protective factors or risk factors that are highlighted. Next slide, please. This basically breaks it down by race and ethnicity. Clearly, we see Black or African American children with much higher prevalence rates of adverse childhood experiences in comparison to other race and ethnic groups. Non-Hispanic whites have the lowest in comparison to other race and ethnic groups. Next slide, please. This is by poverty. You see again a very strong link between poverty, federal poverty lines, and ACEs. So if you see two or more, as the poverty decreases, the number of report of ACEs also decrease with two or more. Next slide. This one, we've kind of really talked about the risk factors. This particular slide is really talking about family resilience. And what we see really is as family resilience increases, the number of reported ACEs decrease. Although this is just a bivariate data, kind of looked at when you account for some confounders, there's almost a 30% decrease after you account for the demographic characteristics and other factors that might influence in predicting ACEs. Higher resilience is associated with lower rates of ACEs or reported ACEs. Next slide, please. And this is more of a social capital measure, which is basically talking about the kinds of neighborhoods they live in, the community around them. So it's similar to the family resilience. Communities with higher or individuals who indicated that they live in communities where there is health, there is sharing, caring, also seem to report lower number of ACEs. So social capital seems to have that positive effect with adverse childhood experiences. So that is the last slide. I don't know if we're going to do the breakout rooms. If you have any questions, general questions, I can address them right now. Thank you.
Thank you very much. And again, apologies to you and everyone for my slide issues here, but we do have a few minutes for questions if you would like to, if you're able to take them, Dr. Hussaini. So
Sure.
folks interested, I personally want to say I appreciate that at the end you were able to include the information on resilience because I think what we're really focusing on heavily here at the SEOW is not only shared risk, but shared protective factors as well. So I appreciate that. And I'm going to open it up to folks. And I see that Leslie, you want to kick us off with a question or comment?
Sharon, really quick, would you like people to ask their questions in the chat or would you like them to be unmuted? Because we have people restricted at the moment. But
Okay.
Relieve that restriction.
No, if you would go ahead and unmute folks, I'm sorry, I apologize. If you feel like you want to put a question in the chat, that's great.
For the moment, everyone is able to unmute.
Okay, great. Thank you very much. Thanks, Dr. Hussaini. We've been, of course, promoters of this particular data set for years and very happy to see it still in the mix. Thank you very much. This is just both a comment and really, I guess, a follow-up question from a methodology standpoint that I think everybody needs to understand that, and this has been a frustration of mine about this study, is that they do not cover sexual abuse, which is one of the traditional ACE items, which is a huge gap, particularly for girls, but not exclusively, girls as well as LGBTQ kids. And for whatever reason that they don't include that, I respect that they don't include it, but I think it's a hugely, it hugely underrepresents exposure, particularly for girls. And I think that's something that I would appreciate if that would always be flagged in these presentations with the national survey. And then the sort of the methodological question around that I have, is there any reason not to include in such a report or such a presentation some other data that would speak to sexual abuse, even though it's a different methodology and what have you, but at least flag it that it's an issue and then share data related to that. Thank you.
Thank you, Dr. Grover. It's wonderful to see you back from retirement. I really appreciate the comment. I think it's a very important point. I think part of the challenge with sexual abuse or sexual use, I mean, it is a very important item. I think it's just, you have to understand the mode of the survey. It's the parental report on the child's experience.
Yeah.
And that itself, some folks can argue may kind of be underreported, for whatever reasons, for several things. And I think just talking from behavioral risk factor surveillance, even adults have, when this question is, I did not include the 2019 Barfus ACE data for 18 and older. I'm going to do a quick infographic, but I think just the sensitivity and the fact that it's been a challenge. I think that's probably the reason that they have never included it in the National Survey of Children's Health. I'm taking a pure educated guess. Don't quote me on this. But regarding your second part of the question, whether or not can we include, I mean, I have not seen questions in sexual abuse specifically in the NSCH data. So if I were to kind of pull this information out from some other surveys where this might be available and combine, it might be a challenge because they're completely different, sources of data. It's not that it cannot be done, but I think unless the design of the survey was similar from any other national survey that enabled us to combine that, it could be done. that if it is a completely different or a local survey, combining those estimates would be just futile. I mean, you wouldn't see anything. I think the most sensitive report of that, again, you know, I don't know if, I don't believe the school survey, whether the Delaware school survey or the YRB is asked that. YRB is asked about, you know, whether you are forced and whatnot, you know, to have sexual intercourse, but it's never captured otherwise in a national survey. So I don't know. I think it's very important. I think people have talked about it, but I think it's just more of the administrative challenges in administering this kind of questions and an interview. And even if let's say theoretically, if it were to be captured, I think the bigger challenge is how reliable or valid the data are. I think that's probably the reason that you know, they're not asking for this vulnerable group, because it could trigger a lot of this. There have been discussion about it. Even in fact, even in Berkeley, I remember when we first asked this in Arizona, and Dale was here, and he could probably give you some feedback. Adults had very challenging. It was very challenging for adults to recollect a very traumatic experience of, you know, sexual abuse, and I think that's one of the core problems with this ACE measure is I think you're completely missing one big piece of the story here. So I completely agree with you on that. Thank you.
Thank you. Thank you.
Any other questions?
There were two from the chat, Dr. Hussaini. Dr. Cooper asked, what is the definition of social capital?
Okay, great question. So there are 4 questions. You know, the way I've created this measure is connected with a neighborhood that you can go to any of the community members that they're willing to offer help. There's one question on that the child feels safe in the neighborhood. It kind of has this safe neighborhood domain. There's other people help out each other. And then reach out. So those are like 4 questions. I can send you the more details, but those are the ones that we kind of use in neighborhood connected kind of variables for social capital. I hope that helps.
Yes, sir. And Dr. Sweetman asks, how was resilience measured?
4 questions again. So the questions are asked members, do you work? Does your family work together to resolve problems? That's one question. The second question is, there's a hope question. So what's the outlook in life? Does your family have a lot of positivity and feel hopeful? And then the third one, if I'm not mistaken, has to do with strengths. What are the strengths in the family that we draw from each other when faced with a conflict? So those are the 4 questions. Whether you solve the problems, what are the strengths, being hopeful, and talking about problems you can comfortably talk about. So that's a key measure of family resilience. And a good inner validity on that. So, well done.
I do want to mention that in the chat, we've posted the link to the data portal for the National Survey on Children's Health. And folks can actually, it's a wonderful tool. You can go in there and you can search on any variety of questions that are asked. They do a bit of slicing and dicing of the data, so you can look at some subgroups. It's not nearly as in-depth as what Dr. Hussaini presented, but it does include like those measures if you want to see specifically what questions are asked for a given indicator. And I would really encourage folks that are interested in this data to take a deeper dive and take a look at that. And perhaps if you have additional questions, you could forward them to us as well. Any other questions from the group before we move on? Aaron Lynch, I'm going to ask you if you would pop into the chat the link to the recent Kids Count session that was done on ACEs, because that provides a little bit of additional information. Okay.
Absolutely. Thank you for the shout out.
Of course. So if there are no more questions at this time, I believe I'm turning it over to MJ. And I think that the conversation at the end about resilience and social capital is a really good way to segue into the next section, which MJ is going to talk a little bit about, give a little preview of an upcoming SEOW report that we're doing. And I'm going to turn it back over to you, MJ.
Thanks, Sharon. All right, I hope everyone can see that. I'm excited to talk about protective factors, positive childhood experiences, or PCEs, and resilience. We have an upcoming report, as Sharon mentioned. We did an infographic on this last summer, which is available on our website. The first thing I want us to do is kind of shift gears and kind of move our brain. And in the chat, if you could, mention something that happened in childhood that you really, really enjoyed that kind of has stuck with you through adulthood. So this could be learning to fish with a family member. This could be culinary classes that you took. It could be basketball. It could be anything. So something that you did when you were a kid that you really enjoyed that has impacted you now as an adult. I'll share mine. Mine is reading. I know you're like, oh, come on, MJ, that's boring, right? But no, for me, reading was a really big adventure. Not only being read to, but adults modeling reading for pleasure. And my grandmother used to read these big, like 600, 700 page murder mystery novels. And we go to the library, and I'm going to date myself. That's when they had card catalogs. So you would go to the card catalog, you'd look for the secret code, AKA Dewey Decimal, and then you'd go for a scavenger hunt to find that book. And now as an adult, I spend way too much money on books. I'm not going to lie. I probably need an intervention. And as a parent, I have passed on a love of reading to my son, who now reads books on mythology and dragons and superheroes and all these other things. So if Solange can Solange call out a couple of the ones in the chat so I don't have to shift from this screen? Can Solange unmute?
There we go. Yeah.
There we go.
I was having a little trouble unmuting. This is fancy here. Okay, so, oh wow, people are going fast. Okay, I am going to read from the last one up. So people are saying road trips and hiking, playing games with cousins at grandma's house. That sounds like fun. Camping with mom, grandma, and cousins. First time biking in the community on their own. Reading as well. Going to museums with family, competitive swimming. Oh, we have some athletes in here. Let's see, hiking and camping. A lot of hikers and campers. Okay, let me go back down. I see some more coming in. Soccer. And hold on, I think I see one more. Oh, hiking again, time with family, and dancing. I concur on the dancing part.
Thanks, Solange. Those are some really good stuff. I enjoy that. And it, obviously no one knew when we were doing that when we were kids that we would now be faced with a pandemic and trying to figure out how to keep ourselves sane. So hopefully we can call on some of that stuff now. When we talk about this topic, we're talking about really three main ideas. Protective factors, which we're using the SAMHSA definition here, which are those characteristics associated with a lower likelihood of negative outcomes or that produce a risk factors impact, right? We see this a lot in public health as well. Positive childhood experiences, or PCEs, are healthy and supportive events, activities, and experiences that occurred during childhood. So PCEs can be protective factors. And resilience. And this is one definition of resilience. If you've been in the field longer than a minute, you know that there's a million definitions of resilience, but typically it's understood to be positive adaptation. We could have a whole other thing about maladaptive behaviors. We're not going to do that today, despite experiencing adversity. I do want to point out that protective factors and resilience occur at the individual level, right? Family level, community level, societal level. And so when we talk about these things, they're happening in different spheres and different domains. One of the key elements, a lot of this is relationships, right? So one example of a relationship framework is the one done by the Search Institute. They're well known for their 40 developmental assets. And so they have these 5 elements of relationships. And we know relationships are key, not only for youth development, but if we're talking about recovery, we know that people in recovery thrive in connection in relationships. So one of the elements, providing support, then they list some actions there for you: empowering the other individual, advocating, setting boundaries. And relationships, of course, are bi-directional, and they have that note at the bottom. So not only what are we doing for young people, but how are young people able to contribute to that relationship? And when we think about support specifically, the 2019 YRBS and the DSS as well asked the questions about sources of support and encouragement. And high school students, this is a mark all that apply question. So a respondent could answer parents, teachers, neighborhood adults, friends and grandparents, and so on. But overwhelmingly, we know that youth receive the majority of their support and encouragement from their parents. When we talk about, sorry, pause for a second, I had to reorient myself. When we talk about parents, we took a deeper dive into this as a protective factor. There are other protective factors in the report, but just to give you an example, 3 items listed on the left-hand side: parents as a source of support and encouragement, students reporting that rules are enforced or strictly enforced most of the time or often. And then there's a block of questions that ask about getting along with your parents, talking to your parents about school. My parents are proud, or show they're proud of me, and I can count on my parents. So when we aggregate this, shout out to Rachel Ryding for that, there are approximately 60% in 2019 of Delaware 11th graders that reported that they ever feel sad, empty, hopeless, angry, or anxious. And when we look at that aggregate on the left-hand side, students that reported 2 or more of these things were less likely to report that they felt that way. When we go even deeper, there's a second question that asks, when you feel this way, do you get the help that you need? And students who reported, or more likely to report these items on the left-hand side, were more likely to report that they received the help that they need. And we see a similar relationship with past month substance use, specifically alcohol and marijuana. Children or youth who reported none of these things were obviously at increased risk of past month substance use, as opposed to students who had 2 or more of these protective factors. And you may be saying, MJ, I don't have kids. My kids are grown. What does that have to do with me? Well, when we look at the National Survey of Children's Health, there's a good question on there about, during the past 12 months, was there someone you could turn to for day-to-day emotional support with parenting or raising children? And gratefully, 76% of national respondents said yes. And Delaware is right behind that, I think like 75.2 or something like that. So right in line with the national average. And then, how well do you think you're handling the day-to-day demands of raising children? 63% of national respondents, and I think Delaware again right behind that with 62%, reported very well. There's another 35% of national respondents that said that they did somewhat well. And if you're a parent or care for small children, you know it depends on the day, right? The one thing I do want to call out here, especially when we talk about the emotional support that parents have, is this rate varies by the nativity of the parent. So were they born in the States or not born in the States, the race of the child, primary language at home. So there's clearly some work to be done in that equity space as well. One example of a state that's doing something interesting around supporting parents is Montana. They have a website called parentingmontana.org, and Bill can drop that in the chat for you. They have an interesting survey on their website. What I really like about it is the way that they framed it, right? Tools for your child's success. Not all the ways parents are messing up. Not a website that says, let me tell you where it's gone wrong. But these are tools and resources for parents to promote success with their children. And it varies by age. So I think 4, if you were to click on 4, there's different, 4 years old, there's different topics like power and defiance. For 14, it might be homework and substance use. And so then it goes into that topic, explains a little bit about it, and then also talks about resources and tools that you can use there in the state. That's a partnership between different state agencies as well as a university there in Montana. So it's a great website to check out. They also did a survey, which is not generalizable because of their sample, but it was an interesting idea that over 90% of parents, when they said what were the skills needed to be successful as parents and what were the skills needed to be successful in life for children, they fell back on social emotional skills. And there are a lot of people in Delaware doing that social emotional work. So I think it's definitely something to keep an eye on and continue to lean into that work as well. And finally, because this is a really quick run through, there's more work to be done, and there's more work for all of us to do, primarily in data collection and analysis. We have done, as a field, lots of studies over and over again on ACEs, which is important and necessary, but there's more to be done in that PCE space. What are PCEs? What are the outcomes of PCEs? How much do PCEs mitigate ACEs? So if I report having 4 ACEs and 2 PCEs, am I better off or worse off than people who have more or less PCEs? So there's work to be done there. One example is the CDC pilot. They recently added some optional PCE questions. So I'm excited to see that data when it comes out. When we think about resilience, not only individual level resilience, but that dynamic relationship between my protective factors and my resilience and with those of my community. And then operationalizing definitions is super important. You know, ACEs recently, in recent years, have expanded. We have those core ACEs, but then there's been work to include things like war zone conflict and being raised in that area, historical trauma. So it's important to kind of come together on these definitions and then look at it that way. And I also want to acknowledge that this requires a shift in focus, right? A lot of us were trained on a deficit model or what's going wrong and we need to fix it, or where is there room to be things to be fixed. And folks come with a lot of strengths, they come with a lot of assets, they have a lot of things going for them. So how do we lean into that, build on that, and continue to work with them in that ACEs or deficit space, but build on their strengths. And then always, always, always culturally responsive interventions, as well as looking at the data with that equity lens. How does this impact different communities? You know, that number, that 76% number of people who have emotional support, that was 76. White non-Hispanic parents reported in the 80s. Hispanic parents or African-American parents were closer to the 60s. So there's clearly work to be done when we work with parents. I'll leave you with one final thought. This is a tweet by a gentleman who is an advocate and does transformational trauma-informed care. His name is Xavier Dagba, and he says, as you focus on clearing your generational trauma, do not forget to claim your generational strengths. Your ancestors gave you more than just wounds. So I know that was super quick. I think we have a minute. If you have questions, I'm happy to take those before we move on to the next presenter. No questions? I love it. This is great. All right. Our next presenter is going to be Dr. Nuno Martins. Let me pull up his slide of DSAM and the Research and Evaluation and Population Health Units. Give me 1 second, Dr. Martins, and I will, David will unmute you and I will pull up your slides.
Okay, thank you.
While we're waiting, I'll just remind everybody we're popping a lot of links in the chat and we'll get those out to you when we send out follow-up. Thank you.
Dr. Martins, you should have access to the screen.
Yes, I have. Thank you so much. Good morning, everyone. Before I start our presentation, I would like to thank, in the name of DSAM, for the opportunity to present one of the projects that we are currently working on at DSAM. And in second place, I would like to briefly introduce myself because I strongly believe that most of you are not familiar with my face and with my background as well. I'm a geographer by training, and I also hold a master's degree in GIS and a PhD in disaster science and management from the University of Delaware. Prior to joining DSAM, I worked for 11 years in academia in the field of emergency management. And I spent most part of my career developing models to assess socio-vulnerability to disasters to understand why people and communities are disproportionately impacted by disasters, and also to think about strategies that can be implemented to reduce disaster risk across communities. Focusing now on our presentation, at DSAM, we have been working in a project for the past month and a half that aims to map naloxone distribution with the use of GIS tools and methods. This is a work that is still in a very preliminary phase. Therefore, today I will be presenting our goals, and I will also provide an overview of our data sets and also some of the GIS methods that we are planning to employ in this project. And we have a team of 4 people at DSAM working this project, comprised of myself, Chris Fraser, Mike Williams, and John Goodslack. And we are also working with Maddie Stenger from the Center for Drug and Health Studies. So I will move on to the next slide. I'm having a difficult time.
One moment, sir. Let me make sure.
Okay, I can control now, I believe.
Okay.
Okay, so similar to the trend found in the US, the number of drug overdose deaths in the state of Delaware has been increasing for the past decade. If we look at the bar chart in figure number 1, we can see that the number of drug overdose deaths in the state more than doubled between 2010 and 2018. And if we look at the data from 2010, we quickly realize that 88% of the overdose deaths involve the use of opioids, which show us the devastating effects and impacts of the opioid epidemic across Delawarean communities. As a result of that, the state has been actively involved in planning strategies, policies, and interventions in order to be able to tackle the opioid epidemic in the state. And one of the policies is actually the distribution of naloxone. However, when we think about the distribution of naloxone, there are different questions that must be raised and answered. In first place, how can we optimize the distribution of naloxone? Where are located the high-risk populations? And where are located the highest values of drug overdose death rates across the state? And we strongly believe that GIS is a very powerful tool to help us to address some of these questions. So I had experience using GIS as a result of my past work in academia, and I used GIS for the purpose of emergency planning. In this slide, you can see 2 maps that I created in past years. In figure number 2 is a map of social vulnerability. It was a map that I created with GIS and multi-criteria analysis to evaluate the levels of social vulnerability in the city of Funchal, is the town of Madeira Island, Portugal. And in this map, you can see where are located the most vulnerable populations. And this is actually a very useful map because in terms of emergency management, high vulnerable populations usually have a hard time to evacuate prior to disaster, because of lack of resources, lack of means. So if we are able to identify these populations, we can plan for the evacuation before a disaster takes place. In figure number 3, you can see a land use change map that I created for the town of Vila Franca do Campo. It's a small town located in San Miguel Island, Azores. And in this map, what we can see is that between 1994 and 2005, there was a urban growth toward hazard areas, areas exposed to earthquakes, to flash floods, to coastal erosion, despite the fact that there were municipal master plans in place that aimed to reduce risk in the town. So there was an increased level of risk resulting from urban growth, as we can see in this figure. GIS is also a very powerful tool to tackle the opioid epidemic. And in fact, several states and counties across the US has been using GIS to establish policies to tackle the opioid crisis. And GIS is a very useful tool because of 3 main reasons. In first place, we are able to collect, store, manage, and display data, different types of data, fatal and non-fatal overdose data, hospitalizations data, naloxone distribution points data, and even the location of treatment resources for the population struggling with addiction. In second place, GIS has excellent geospatial modeling capabilities. For instance, as you can see in figure number 4, with GIS is possible to see the variation in the levels of drug overdose death rates across the state of Delaware. As you can see in figure number 4, with data from 2011 to 2017. And at the same time, we can also optimize the distribution of naloxone using their geospatial models as well. Therefore, GIS is important in terms of policy making, decision making, because it can support these important decisions that must be made at the state level or at local level. And finally, GIS has different tools like dashboards and story maps that can be used to communicate the opioid risk with the Delawarean communities and other communities across the county, the country. Taking into account the potential of GIS, we outlined 4 main objectives for our project. In first place, we want to identify the hotspots and cold spots of drug overdose deaths across the state of Delaware. In second place, we want to map the location and the volume of naloxone distribution across the state. We want to understand where, when, and how many kits DSAM has been distributing across the state. In third place, we want to identify gaps and disparities in the access to naloxone, and we can conduct this work by overlaying 2 layers of information: drug overdose death information and the naloxone distribution points information and data. And finally, we want to be able to map high-risk populations for opioid use by using different demographic and socioeconomic variables that can be used as predictors. For the purpose of this work, and we are still in a very initial stage, we will be working with 4 different data sets. We will be using the DSAM naloxone distribution data. So every time DSAM organizes an event to distribute naloxone, we keep record of that event. Where did it take place, when, and how many kits were distributed. We will also be using the death investigation alert data. So every time that there is a suspected overdose death in the state of Delaware, DSAM receives a notification, an alert, and that alert has individual level data with information about the victim, like demographics, place of death, like the zip code, place of residence and the zip code, and we will be using this data for the purpose of our analysis. We will also be using the consumer reporting form, the CRF data, which is a primary data collection tool for DSAM clients receiving treatment for substance abuse and mental health services through DSAM. And we collect data from all phases of treatment, from admission to discharge. And we have different measures that we can use for the purpose of our work. And finally, we will be using American Community Survey data because it has a good amount of indicators that we can use, demographic, socioeconomic, indicators that can be used to identify high-risk populations for opioid use across the state. Focusing now on our analysis, we haven't started the GIS analysis yet, but we would like to provide a very brief overview of our initial approach. So the DIA data and the Naloxone distribution data will be aggregated at the zip code level. So the analysis will be conducted at the zip code level. Then we will use a tool in GIS called hotspot analysis that will allow us to identify hotspots and cold spots of drug overdose deaths in the state of Delaware. Then, in a third phase, we will be conducting an overlay analysis, and there are different tools that can be used in GIS to perform the overlay analysis. But overall, we want to determine the geospatial relationship between suspected overdose deaths and the naloxone distribution points to help us identify the gaps in the access to naloxone across the state. And finally, we will be creating different demographic maps in order to identify the high-risk populations. And we will be using different variables. Age, gender, race, income, employment are some of the variables that we will be employing for the purpose of this work. Finally, expected outcomes. The first one is that we aim to improve the distribution of naloxone in the state based on the results and findings from our analysis using GIS. And if we manage to optimize the distribution of naloxones, we will be able to decrease the overdose deaths, since naloxone is a very effective drug to reverse opioid overdoses. And finally, we also aim to improve risk assessment. For the purpose of this work, we are trying to use GIS to optimize the distribution of naloxone. But if we learn more about the opioid epidemic, conducting this kind of analysis, we will also be able to think about other strategies and policies that can be implemented to help the state and the Delawarean communities to fight the opioid crisis. I would like to thank for your attention, and I'm happy to answer your questions and to receive your feedback, suggestions, and recommendations. Thank you so much.
Thank you, Dr. Martins. Did anybody have any questions?
MJ, I do have a question.
Yes, GIS master for CDAS, yes.
So, Dr. Martin, when you're doing the hotspot analysis, when you're plugging the data points in, are you plugging them in at the zip code level so the hotspot analysis can only take it down to the zip code? Or will the hotspot analysis allow for you to drill a little bit deeper than that? Because some zip codes in Delaware are so large that I'm wondering how informative that is.
Jim, do you mind repeating your question, please? I had a hard time listening the first part of the question.
Not at all. So when you're geocoding the overdose death locations, are they geocoded at a specific address, or are they geocoded just at a zip code level? And my question is, if your hotspot analysis, how specific are the hotspots? Are they only down to a specific zip code level, or can you drill down to like specific census block or census tract levels within a zip code?
Jim, thank you for your question. It's actually an excellent question, but take into account the data that we have available for now. The analysis will be conducted at the zip code level. but you are raising a very important question. But for now, the analysis will be taking into account the data that we have available. The analysis will have to be conducted at the zip code level.
Thank you. Our CDHS heat maps are done at the zip code level for some of the same reasons as for those limitations. So I was just curious if you found a way to get through to that. Thank you, Dr. Martins.
Yeah, but that's let me follow up on your final comment. We are in a very preliminary phase, and we want to explore ways to try to overcome those methodological limitations. But since we haven't started the analysis yet, we still don't know if it will be possible to overcome some of these methodological weaknesses that we might find. Yeah.
A second question, and I'm sorry, are the overdose deaths, are they the residency of the victim, or is that the location in which the individual body was found, where the body was found?
We have, okay, another good question. We have both information. We have the place of residence, but we also have the place of death. In this case, we have the zip code where the suspected overdose death took place. Yes.
Thank you very much.
There's room for Jim and Dr. Martins to collaborate. Anybody not Jim have a question?
I want to point out that Megan Pell had a question in the chat, and can you hear me? She basically, is talking about the mapping and what applications might be a good start, what technology might be a good start if you wanted to apply, if you wanted to start learning how to do this kind of a process. So I will ask Dr. Martins first, and anybody else, Jim, that has a recommendation of how to go about learning how to work with these mapping systems.
Dr. Martins, did you have any thoughts?
Sorry, do you mind repeating the question? I'm very sorry. I was typing, I was making myself available to answer any questions via email, and I'm so sorry. Do you mind repeating the question, please?
Sure. So how do beginners get started, essentially, in GIS mapping? Where would you recommend folks get started? Whether that's applications or anything else?
Well, that's actually a very good question that you are raising, and I would say that many states across the country have what we call web ArcGIS apps that random users can explore, and these web GIS applications offered by different states, even Delaware has these applications, allows the users to conduct some more basic analysis, some more basic geospatial analysis using different operators that are available through the online GIS. So that's the easiest way to start, is to go to a state ArcGIS platform. In Delaware, we have for public health, for example, and explore the different data sets that are available, some of the geospatial analysis that can be conducted through the web ArcGIS. So that's the easiest way to start. At the same time, I believe that there are some introduction courses as well that are offered by different institutions that allows individuals to become more familiar with the different capabilities of GIS. So there's different ways that that a person can become more familiar with GIS, And I'm reading in the chat, ArcGIS also offers some resources for people to be able to explore some of their tools. Yes.
Dr. Martins, Bill Lynch had a question. Have you considered incorporating info from ODMAP?
No, not really. Not for now. Like I said, we are still in a very early phase. We are so in this early stage, we are more conducting like an exploratory analysis, but we are considering, of course, there are different data sets that we would like to use. For instance, non-fatal overdose data is one example of data that we would like to be using. We would love to have access to data about naloxone revivals. That would be amazing to work with. But in this first stage, we will be using the data sets that we have available. But of course, we are looking for ways to work with other data sets that will be very informative to be able to have a full portrait of the opioid epidemic in the state of Delaware. And we also would like to map some resources that are available for the communities and for people struggling with addiction. I think that will be very interesting to add to our geospatial information. But like I said, it is still a work in a very early phase, but we are open to different suggestions and recommendations regarding different data sets that we can use. And in fact, I will add my email address. So please feel free to send me your recommendations, suggestions, or if you have specific questions, please feel free to email me, please.
Dr. Martins, the reason I bring that up is that this has been an extremely successful program throughout the entire state of New Jersey. New Jersey actually leads the country with using ODMAP.
Okay.
The reason that's important from a healthcare perspective is because we're able to identify an outbreak as it's occurring, get that out to law enforcement and healthcare professionals, and actually stymie an outbreak that's actually occurring as it happens. I mean, that's how progressive this has been. The reason I bring that up is because I can put you in touch with Detective John Bardunas, who's led this initiative for the New Jersey State Police, Sergeant First Class Adam Polhemus, who actually heads up the unit. I'm sure they'd be more than happy to talk to you about how they've used ODMAP, and they report these things. It was going back to even Jim Heiberger's question with regards to zip codes. This will give you exactly the place that these things occurred. And if you see these outbreaks, you can mobilize resources there, both naloxone trainings, I mean, all kinds of things that have happened because of it. So I was very impressed with all the data sets you're looking at already to put together, but this probably would be one to consider that would enhance the information you'll be able to provide.
Okay, William, thank you so much for your feedback. If you could please send me an email with that information, I really would appreciate it.
Absolutely. I'll put my email in the chat for you as well. Thank you.
Okay. Thank you so much, William.
Thank you, Dr. Martins, for your generous offers and also that really great presentation. I'm going to turn it now to Sharon to bring us home and to share with us a final section of information.
Thank you, everyone. MJ, I'm going to ask you to advance the slides for me, if you don't mind. I don't want to spend a whole lot of time on this, but I just want to thank everyone that has participated in the satisfaction survey that we conducted last year. We did have about 29 folks participate in this survey that was intended to give us some feedback on what we could, what they found to be most beneficial and what we thought we could do to enhance the role of the SEOW. So what we found is that the needs for data were vast. Folks are using data to raise awareness, to plan programming, to conduct evaluation, to analyze and develop and advocate for policy, and most importantly, apply for funding. And they were also using it for research and to train folks and generate community engagement. Next slide. Again, we offer a very wide array of products, from everything from infographics to massive reports such as the Epi profile. We recently produced the Epi for 2020 along with an infographic series. We've created Venn diagrams. The heat maps that we just referenced were also considered to be very valuable to the use of folks who access our services and responded to this particular survey. So again, the needs are varied, the resources that they look to are varied. And we also asked a question about what they did with the data, how they disseminated it. If you'll go to the next slide. We found that 3 out of 4 folks who responded are in fact sharing the data with other networks. They might incorporate it into publications. They might put it in reports or presentations. One of the things that we offer is we post our slides. We post them in a format that will allow you to pull the slide out and use it for a presentation that you're giving. So we really want this data to go into the hands of folks where it will do the most good. We were really delighted to see that more than half of the respondents actually share the data with government agencies, either through their own role or they submit it to them. And perhaps the most surprising thing for me was that at least half of the group that responded share the information and the data with legislators. So we know that folks are using this to try to affect systems change. We also, as many of you on the call know, we do offer technical assistance throughout the year. In addition to creating these products that we post online and these meetings, we do some customized technical assistance. So if there's data that you're interested in and you cannot find it in a report or a presentation, you're free to come to us, and to the extent that we can help you get what you need, we will try to, we'll help with analyses, or we will put you in touch with folks that might have that information. Sometimes, as we've just discussed, the limitations of the data can be considerable at times, and we try to help people think through what it is that they need and how they might get answers to their questions, and how they might frame things in a way so that they can have data to support what they're trying to do as a launching pad, perhaps for further exploration. And we also did note from the folks that participated in the survey that most of them had participated in at least one of these SEOW meetings in the past 2 years. Next slide. So we did have a lot of positive feedback on the services and the products that we are currently rolling out, but we did have some suggestions for, to increase our capacity to help and to support your efforts. One of the things that we were hearing was continue with that focus on shared risk and shared protective factors, particularly things at the community and environmental and societal levels. Folks are definitely looking to intervene at the outer bands of the socio-ecological model. We had one recommendation to co-host a research forum for a broader audience than our stakeholders, and this is something that we'll explore. And as an outgrowth of that, we did decide to launch a webinar series called 3D, Delaware Data Discourse. We had our first webinar in the month of December, where we did an overview of the highlights of the annual Epi Report. We hope to roll these out on a more consistent basis. In addition to that, and along the same lines, one of the recommendations was to try to push out little bits of information more frequently. One of the things that we definitely need to improve was our social media presence, and we think that that's certainly one way in which we can do that. So that's on the horizon for the next year. And that's about it for this. We would encourage folks, this is a segue into saying that we're just about at the end of our schedule. We're at the end of our scheduled time, unfortunately, past that. But we want to remind folks that the products that we have are all online. There's the website for that, and that we'll have our next semi-annual meeting in the summer, probably late June or early July. And that we will be sending information out routinely about new resources, and especially about our new data discourses. And then we want you to continue to reach out to us with recommendations and to let us know what your data needs are. With that, I'm going to simply open it up to conversation for those of you. Thank you for sticking with us. We had a lot of information shared. We're going to unmute everybody's microphones. We welcome everybody to share out what they'd like to. If you'll go to the next slide, I just wanted to say that folks who might be new to this group and want to introduce themselves, we would welcome your opportunity to do that at this time. But everyone is welcome to share news about what they're doing and what's happening with their particular organizations.
Sharon, this is MJ. I'm going to kick it off. I did not prepare Mr. Elkins for this, but I'm going to do it anyway. My bad, Mr. Elkins. Mr. Elkins, Daniel Elkins of Bellevue Community Center, is actually a new member to the SEOW, but really exciting. He has recently been awarded, or his group has recently been awarded, a drug-free community grant, which is huge for the state of Delaware.
Wonderful.
So a huge round of applause for Mr. Elkins and his group, and if he wants to unmute himself and talk.
Very
Hello,
nice.
It is an honor to be here. I have learned so much in the last 2 hours. My head is beginning to explode, but thankfully this has been recorded and I can't wait to go back and review it with the team. Thank you so much for all of the work that you are doing. Data-driven policies and prevention strategies is the core of what we need to be doing for our entire state. And I am just so thankful that this resource is being made available to us. And thank you for having me as a part of the group.
Congratulations and welcome. That is so wonderful. Would anybody else like to join in and introduce themselves or share some news about what's happening? Okay. Well, if no one else wants to add anything, you can certainly put it in the chat, but if no one else is wanting to talk, that's perfectly fine. We certainly understand it's been a long morning, even though it's been action-packed. And we are so excited that you're here, that you joined us today, and we are looking forward to our next meeting and looking forward to our data discourses, and certainly from hearing from you throughout the course of the next months. We wish
Sharon, I want to give one more shout out. I remembered another shout out, sorry. I want to applaud Mr. Gibbs and the entire Mid-Atlantic Public Health Association for a successful first conference. It was really, really great. Those recordings are going to be available soon. So if you get a chance to check them out, I'm excited that they recorded it because you can only watch one at a time, right? So I was attending one, but I'm excited to go back and look at those other recordings. So great job on that.
Well, thank you very much.
That's wonderful.
Sharon, it's Bill Lynch. I just wanted to end this call with some good news. There's actually preliminary data now showing that naltrexone combined with bupropion may be beneficial in treating methamphetamine addiction. That's the first information we have of any potential antidote like a naloxone for opioid.
Wow.
Combine naltrexone with bupropion. Ironically, those two medications did not work well individually, but when combined, showed some benefit in treating methamphetamine addiction.
Bill, that's great. If you have a citation for any of that, or when you have a citation, either pop it in the chat or send it our way so we can get it out to folks. Thank you. That's great. All right. I don't want to keep anybody any longer, but thank you again for your time today. Thank you for your very hearty participation and your support of the SEOW on behalf of the team. Go out there and have a great few months. I mean, maybe we'll be meeting together in person in the summer, who knows? But if not, we're going to keep on keeping on. So thanks to everyone. Take care and have a great rest of the week.
Thank you, everyone.
Thank you.